Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gynecologic, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are joined by GYN oncologist Anna Beavis, an assistant professor of GYN oncology here at Johns Hopkins at the Kelly Gynecologic Oncology Service, which is within the Department of GYN and Obstetrics. January is Cervical Cancer Awareness Month, so we've invited Dr. Beavis to discuss cervical cancer, and we also will touch on some other GYN cancers as well. So, Dr. Beavis, it's my understanding that overall in the United States alone, we have about 100,000 women that are diagnosed with some form of GYN cancer each year. What are the more important risk factors that women should keep in mind?
The risk factors for gynecologic cancer actually really depend on which gynecologic cancer we're discussing. So gynecologic cancer includes ovary cancer, cervical cancer, as you mentioned. In addition, uterine or endometrial cancer, we use those terms interchangeably, as well as vaginal and vulvar cancer. And each of the cancers has their own set of risk factors and their own set of signs and symptoms.
If we took a look at cervical cancer, what would be the best way for our audience, which is primarily lots of women out there who have cervixi, to go about making sure that their cervix is healthy?
Cervical cancer is one of the biggest triumphs of public health in the last century. Cervical cancer used to be a major killer of women, but we have had major advances in the ways that we can pick it up and in the ways that we can prevent it in the last several decades. So women need to know that most cervical cancers, in fact, over 99.7%, are caused by the HPV virus, and that's the human papillomavirus. That virus is primarily transmitted through sexual contact, whether that be through sexual intercourse or just other genital sexual contact. And so most of us will have it in our lifetime, and most of us will clear it. But in some people, it can progress to a precancer in the cervix or a cancer.
So when you say most will have it and most will clear it, can you describe what you mean by clear it?
Yeah. It is a concept whereby we can detect HPV in most people if we were to do an HPV test of the cervix. We don't have a routine test for HPV that's performed on men for screening. But for women, we do a pap smear that looks for changes from HPV in the cells of the cervix. And now we also have a test that actually tests to see is there HPV present in those cells. Some women will have that HPV be present without changing their cells in any way and without progressing to cancer. And so we now think that probably 80% of people at some point, if we were to test everyone, we'd find HPV in their genital tract, and most people, it wouldn't progress to anything.
Does a woman need to ask her gynecologist to do a special kind of pap smear in order to figure this out?
There's 3 different ways that we screen for cervical cancer or try to pick it up early, and all are considered acceptable. One is the pap smear that we've had since the 1950s. The gynecologist will look at the cervix and then take a brush and essentially take a sample of the cells on the outside and just on the inside of the cervix. The cervix, when you're looking at it, kind of looks like a tiny donut, has a little hole in it called the os, and so we make sure we get cells from both the inside of that and the outside. A routine pap smear would just be looking at those cells. And then we can also send that sample for an HPV test. And that's called co-testing when we send both together. That's the recommended approach for women over the age of 30. And if both of those are negative, then a woman doesn't actually need to have a pap test or a co-test for another 5 years. And just recently, last year, HPV testing alone, without looking at the cells, but just looking for HPV, has been approved as a way of screening for cervical cancer because it's just as good as doing both together, but actually might pick up more cervical cancer or precancer.
So I understand that smoking is also a risk factor and that women who smoke are nearly twice as likely as non-smokers to end up being diagnosed with cervical cancer. I know that our audience that's listening probably has teenagers that they are concerned about. Maybe they're going to be sending them off to college soon. and we want to make sure they're not adopting unhealthy lifestyle behaviors, and frankly, we know they probably are. So whatever we can do to educate parents to then in turn educate their children. Diet also, that 15-pound weight gain that people talk about for their freshman year. And can you tell us a little bit about the use of the birth control pill? What impact may it, if any, have on cervical cancer?
In order to try and understand who is at risk for cervical cancer and what are some of the risk factors, there have been many studies that have looked at hundreds of thousands of women and tried to pick out, which are the risk factors that really separate these women who do have cervical cancer from women who don't. So smoking is a great example. I talk to a lot of women with cervical precancer and cancer about the relationship of smoking cigarettes with the development of their precancer or potential progression to cancer. And most people know about the relationship of lung cancer and smoking, but many people don't realize that many other cancers are actually, you have increased risk if you smoke. So you can actually stop smoking, and if you have precancer, potentially help reverse that precancer and help it go away. So I think smoking is a wonderful thing to talk to young women about for many health benefit reasons, but cervical cancer is certainly top on my list based on what I do. Diet is probably less because we know that this is caused by HPV primarily. Diet and exercise, while they're wonderful things for other health reasons, and we won't be discussing it today, but certainly uterine cancer is related to being overweight and sedentary. So adopting a healthy diet and lifestyle I would encourage. But there are some other risk factors, like you mentioned, oral contraceptives. This is very controversial. There have been many studies that have been done that have shown this relationship, and I think there is a large proportion of scientists and physicians who really feel that when you see that relationship between oral contraceptive use and cervical cancer, really what we're capturing is the relationship between sexual activity and cervical cancer. And so our statistics can't prove that, but there's no biological mechanism whereby we'd really expect oral contraceptives to put you at increased risk for cervical cancer.
So sexual activity is definitely where the rubber hits the road, doesn't it? And concern that for young people are oftentimes engaging in sexual activity under the age of 18. It kind of become the norm, whether it's good, bad, or indifferent. It's something that I think we need to accept. Also not unusual for a girl to have different partners over a period of time as well, including at this age or potentially even younger than that. And I understand that having many sexual partners bumps up that risk, and it's obviously because she's being exposed, right, each time that the individual that she's partnering with for that evening, night, morning, whatever, all of the experiences he or she has had gets brought along to this party. That's something I think that parents really do need to stress in their children. We shouldn't just rely on the middle school health nurse education. For our kids, parents need to sit down and probably get brave because they're not comfortable talking about this subject, but they need to be Dr. Ruth for a little bit and talk to their kids to keep their children safe. There certainly are commercials on television today, or maybe infomercials would be better for me to describe it, that is promoting the use of the HPV vaccine. And it certainly does demonstrate in these infomercials clearly that this is a way that we can protect our children.
Yeah.
It also is a way that we can protect our sons, too, interestingly enough. For those out there, if you're perhaps on Jeopardy tonight and they happen to have an HPV column of questions, men can also end up with a form of cancer, and that kind of cancer is head and neck cancer, so throat cancer, mouth cancer, tonsillar cancer, and that's why we also want to have boys and young men also be vaccinated. Is incredibly important. Let's talk a little bit about having children. Today, we don't see huge families like we did back in the 50s where there may be 4 or 5 kids. Now it's usually 1 or 2 children that people are having, but I understand that having 3 or more children, giving birth to 3 or more children, may bump up that risk a little bit. I don't think that people will probably decide how many children they want to have based on that element, but it still is good for our listeners to understand. What about the age to start our family? Becoming pregnant that first time, are there any age recommendations based on risk?
No, certainly I wouldn't recommend choosing when and how many children to have based on your risk of cervical cancer. The risk of cervical cancer for any woman in the United States is 0.7%. So the risk is very low, but it can be a very devastating cancer when it does develop. Going back to talking about number of sexual partners and adolescents beginning sexual activity a bit earlier than they used to, I think it is really important to know about the HPV vaccine. You mentioned boys also needing it too, and actually about 40% of new HPV-related cancers are in men. So the HPV vaccine now protects against 9 types of HPV. It's approved for both boys and girls starting at age 9, and actually all the way up to age 45 if you miss out when you're younger. But as any vaccine, it works better if it's given before you're exposed, so before sexual activity, which is why it's recommended to be given around age 11. That vaccine is now protecting against 90% of cervical cancers. Australia has actually demonstrated in some of their studies where they've been able to increase vaccination at a much higher rate than the United States. They predict that they'll be able to eliminate this as a cancer in the future.
Isn't that extraordinary?
It's a huge potential.
Tell me a little bit about family history and what impact it may have on risk.
Because this is a viral related cancer, family history doesn't have any, really, if a family member has a history of cervical cancer, it doesn't put their daughter at any increased risk of cervical cancer.
That's relieving to hear.
Yeah.
I'm sure is also to our audience. I'd like to switch gears a little bit and talk about ovarian cancer.
Okay.
Every year, there's approximately 22,500 American women who are diagnosed with ovarian cancer. I have also seen quite a few patients myself. My specialty is in breast cancer, and in particular metastatic breast cancer. We see women who carry a BRCA gene mutation and also may present at the same time or later, or even in the reverse order, ovarian cancer first, then getting breast cancer as a result of that. Can we talk a little bit about ovarian cancer prevention? Is there any way to prevent ovarian cancer, and who should be worried about this?
The chance of getting ovarian cancer in your lifetime is around 1.4%. It's very low. However, there are some women who are going to be at increased risk who might warrant increased screening or increased testing when they're younger. So you mentioned patients who have a BRCA or a BRCA mutation. Those women may have up to a 40% chance of getting ovary cancer in their lifetime, and they should seek care with a GYN oncologist starting as early as age 25. And that's primarily so we can follow the ovaries with ultrasounds and do blood tests to make sure if anything starts to look like cancer might be developing, that we could catch it earlier. It also helps because then we can talk to women about potentially having surgery to reduce their risk of ovary cancer by removal of either the fallopian tubes and ovaries, or fallopian tubes first and then ovaries later. The reason I mention that is that recent data suggests that perhaps the majority of ovary cancer actually begins in the fallopian tubes. So if a woman has completed childbearing, you can consider removing the fallopian tubes as a form of birth control. That could also be a way to reduce the risk of ovary cancer. We've known for a long time that tubal ligation reduces your risk of ovary cancer. In women who do not have an increased genetic risk, and I should mention also that Lynch syndrome is another syndrome where there is an increased risk of ovary cancer, and those patients should also seek care with a GYN oncologist. But in women who don't have that increased risk, the first thing they should do is talk to their family and make sure they don't have a lot of ovary or breast cancer in their family history. And if they do, speaking to their primary care physician or gynecologist to determine whether or not testing for genetic abnormalities would be a good idea, would be a first step. If they don't have that, then there are ways to prevent ovary cancer, even in just the general population, so women who aren't at increased risk. Using birth control pills can actually reduce your risk 40 to 50%.
Which is huge.
It's huge, yes. And ovary cancer is often advanced stage when we diagnose it and very difficult to cure. So
a silent killer.
Yes, oftentimes there are no symptoms, and I can't tell you the number of my patients that will ask, well, how long has this been here? How could I have missed this? The symptoms are very hard to pick up. They're mostly bloating, abdominal pain, and things that happen in most of us a couple times a week.
Could be confused for eating a big piece of cheesecake and thinking that you're having a gallbladder attack.
Yes.
Right?
Certainly. Age is a risk factor. Most women are going to be diagnosed in their 60s. In women who have a genetic risk, it's going to be younger.
How about hormone replacement therapy?
The relationship with hormone replacement therapy and ovary cancer, we haven't fully established that as a causative factor. There's also some studies looking into fertility treatments like in vitro fertilization, and the jury's still a little bit out on those. In general, with hormone replacement therapy, we recommend hormone replacement for the shortest period possible. For women who have a BRCA mutation and actually have their ovaries removed earlier, it does appear safe to give hormone replacement therapy up to the average age of menopause for those women, so long as they don't have a estrogen-related breast cancer.
Okay. And certain fertility drugs, is there any issue with them?
There have been some studies to suggest there may be an increased risk, but we don't know for sure.
You talked a little bit about some of the symptoms, that bloating, not quite feeling right, usually loss of appetite, a sense of feeling full when they really haven't eaten that much. I know some women have other GI issues, diarrhea, constipation, something that's irregular about their normal bowel practice. What other types of symptoms might present themselves?
So you've really covered the most of the ones that we see. So it's abdominal bloating. Most women just feel that something isn't right. Something has changed in the way their abdomen kind of feels. And I often see women who have seen a gastroenterologist and had a colonoscopy and it looked fine. And it wasn't until a few months later that someone said, oh, let's do an ultrasound of the pelvis, or let's do a CT scan. As a woman, you're in touch with your body. You know, for example, you've had periods probably for a lot of your life, and you know when something doesn't quite feel right. So it's this bloating, pressure in the abdomen, feeling like you're full earlier, or your bowels have just kind of changed. Certainly seeking out care from a gastroenterologist is appropriate for gastrointestinal symptoms, but also considering asking your primary care doctor about other things that could be causing this, particularly in women who are in their 60s, the average age of ovary cancer.
Also, I know women may feel extra fatigued. They're just kind of sluggish, not bouncing back, I guess I would say. Even patients, unfortunately, that may have disease that's progressed along a bit, they even have some shortness of breath.
Yes.
Because the cancer, unfortunately, may have spread on to other organ sites, including building up a fluid that affects their ability to breathe well. What are the most effective ways to diagnose ovarian cancer? You mentioned ultrasounds, and I'm assuming that's a transvaginal ultrasound.
Yes. Ultrasound is really the best imaging test we have to look at the ovaries themselves. That can be done either transabdominally, meaning they put the ultrasound probe on the abdomen, but ovaries are often quite small and the very top of the vagina is right by where the ovaries are. And so placing a ultrasound probe through the vagina to look at the ovaries that way, as you said, a transvaginal ultrasound, which most women report is somewhat uncomfortable, but no more uncomfortable, say, than a pap smear, is a good way to look at the ovaries.
I've had that done several times, actually. I think it's because we require the patient to have a full bladder. That's the trick. It helps move other things out of the way to be able to see the ovaries and fallopian tubes more clearly. I can remember when the physician was doing this, she said, I'm going to be inserting a wand. And I said, I bet it has no magic in it. And she said, you're right, there's no magic. I said, well, but it's going to tell us if I have a concern or not, isn't it? She said, that's absolutely right. I said, well, then there's a little bit of magic in it.
Yeah.
What about the use of like CAT scan?
So the CAT scan is a scan that can look at a much larger area of your body. So the ultrasound is kind of a focused look at the ovaries. And in a woman who, let's say, is postmenopausal, so they've gone through menopause and they have a mass on an ovary detected on ultrasound, their physician might recommend then doing a CAT scan to look and see if there's any evidence of a cancer that could have started in the ovary and then spread. So the CAT scan doesn't look as well at the ovary architecture and exactly what is in the ovary, but it's very good for looking for areas where it may have spread. And it may be the first test that a patient has done if they have any symptoms or signs that are concerning for cancer that may have already spread. For example, increased abdominal bloating consistent with potential fluid. In that patient, a CAT scan is probably your best first test because it's going to give you a picture of the whole belly.
What about a blood test? We have some, I'm going to call them tumor markers for other kinds of cancers. What is available to be able to potentially learn a little bit more as to whether our ovaries and or fallopian tubes are in trouble?
We most frequently send a test called a CA-125, and that is most commonly elevated in advanced ovary cancer of the most common type, which is called epithelial. It's just a certain type of ovary cancer. In a woman who has a mass in their ovary that's concerning for a cancer, we'll often send that test. And if it's elevated, that will raise our suspicion that it could be a cancer in her ovary. And in combination with that, plus the CAT scan, it can help the physician really know whether they're suspicious that this is a cancer, and if it is, if the cancer has spread. There's other types of ovary tumors that secrete slightly different tumor markers. So for example, there's something called a granulosa cell tumor that produces another tumor marker called inhibin. A physician would go through the symptoms that a patient is having to help them decide which tumor markers to send. But primarily we send the CA-125, and then because cancers from other sites can spread to the ovary, we'll often send a CEA, which is a test that's sometimes elevated in colon cancer, and sometimes a CA-19-9, which is elevated in pancreatic cancer.
My specialty is breast cancer, and I know that we certainly do see and treat patients who have invasive lobular carcinoma that develops into stage 4 that is spread onto other organs, and one of the places it does like to go is the uterus, the ovaries, unfortunately also the GI tract and some other places, even the adrenal glands. With CA-125, I want to comment and just let our audience know that this test is not the kind of blood test that says, yep, you've got ovarian cancer. I said, quite frankly, you could get your flu vaccine today and get your CA-125 tumor marker done 4 days from now, and you'll be convinced you have ovarian cancer because the CA-125 can be a false positive. It can elevate very high for other reasons. Some reasons we do know, like getting a vaccine, flu vaccine. Other reasons we actually don't know. So I don't want anybody panicking, saying, oh my gosh, I happen to know what my number is. And my doctor said not to worry, that he may know something or she may know something that you don't know, so have that conversation. Certainly before we would want to treat a finding to be that of ovarian cancer, we need to get some tissue. So how would a biopsy go about being done since this is inside of her abdominal cavity?
With ovary cancer, it depends on the imaging that has been done and the suspicion for disease spread. So do we think the cancer has spread outside of the ovary? Because a cancer that has not spread outside of the ovary and is just confined to an ovary is the earliest stage of cancer, called a stage 1A, and may not require any additional treatment, we don't recommend biopsying the ovaries themselves. So we actually recommend typically doing what's called a laparoscopic removal of the ovary and fallopian tube from either that side or both sides, depending on the patient's age and counseling with their doctor. We wouldn't recommend sticking a needle through the abdomen and into that mass because it could spread cells. However, in the case of someone who has a mass in their ovary, but evidence that the cancer may have spread, it's completely appropriate to place a needle through the skin under light sedation with some numbing medicine to pull out some cells from that area, whether it be, most commonly, I would say that's the omentum, which is this fat pad that lies on top of the intestines, so that a diagnosis can be made without necessarily undergoing that surgical procedure.
Let's talk a little bit more about, once this diagnosis has been made, what some of the treatments may be. And you mentioned stage, so we always like to identify at an early stage if we can.
Yep.
We've also talked about the fact that this is a sneakier cancer than quite a few others, so it can be more difficult to catch it early. From a surgical perspective, what is commonly done?
Depends on the stage, but in general, if someone doesn't have any evidence of spread outside of the ovary, then we would recommend a procedure where the ovary and the fallopian tube are removed. And often here at Johns Hopkins, we will send that for a frozen section, where we have wonderful expert GYN pathologists who will look at the tumor under the microscope and be able to often give us a diagnosis during the same surgery. If then we encounter a cancer, most of the time the remaining surgery will involve a hysterectomy, removal of the uterus, removal of the other ovary, the other fallopian tube, and then removal of lymph nodes and that omentum that I mentioned in order to make sure there hasn't been any spread. And there are certain cancers where it's not necessary to remove the lymph nodes necessarily, and certain cancers in young women where we can actually save the other ovary and fallopian tube. But those are obviously very nuanced decisions.
So something that you just mentioned, I want to reiterate to our listeners, is the value of having a pathologist who specializes in GYN oncology. The same for breast cancer, the same for pancreatic cancer, other cancers that we've discussed in these podcasts. It is worth the time and effort that if any of you out there, heaven forbid, are diagnosed with any form of cancer, frankly, before you choose where you're going to get your care, make sure that they have pathologists who specialize in the kind of cancer you have, because the pathologist holds all the cards. Their accuracy determines, frankly, your fate, because it drives what the treatment decisions are going to be. Let's take a look at chemotherapy. How often is that recommended?
So chemotherapy is typically recommended when there's been any spread of ovary cancer. We talked about surgery for what I would say is an early stage cancer that we are then trying to figure out if it's spread. If a woman, and this is unfortunately the more common situation, if a woman already has spread, then we recommend performing, if it's possible, and here at Johns Hopkins we really truly believe in what's called a cytoreductive surgery. That's aggressive surgery to remove all of the cancer everywhere that we can see it. Sometimes that means removing a piece of the bowel, sometimes that means removing a piece of the spleen in addition to the other surgeries I mentioned. But that really can impact how a patient does, and it also impacts how well the chemotherapy is going to work for that patient. I think that's really important for patients to know as well. I think one of the most helpful things at Johns Hopkins is having those expert pathologists, but we also have teams of physicians who can help achieve what we call an optimal cytoreductive effort, meaning we got all the cancer out.
Like yourself.
Yes.
Yes. Mm-hmm.
That's always the goal.
Mm-hmm.
And we will work as long as hard as it's necessary to do that. And we also have to take into account sometimes that's not going to be possible for some patients. And those patients, for example, if they have tumor in the blood supply to their small bowel, we can't take out all of your small intestines, you just won't live. So in those patients, we recognize that early, don't proceed with more surgery than is necessary, and then start chemotherapy as soon as possible with the goal of then going back in and doing a cytoreductive surgery 3 or 4 cycles of chemotherapy later. So you asked about chemo. Mm-hmm. Often chemo is given in the IV, although for some ovary cancers it may be appropriate to be given actually directly into the abdominal cavity in addition to in the IV. And when I say IV, I mean in the vein.
Right.
Typically it's given as an infusion. Cycles are every 3 weeks or so. Depending on the type of chemo you're getting would depend how many times you come back into the infusion center to get that chemotherapy.
Immunotherapy is becoming a new buzzword out there, a very exciting buzzword too. Where are we with immunotherapy and ovarian cancer?
Currently, there aren't any ovarian cancer-specific FDA approvals for immunotherapy. However, pembrolizumab, which is one of the immunotherapies that was approved last year, is approved for any tumor which has certain genetic mutations. And our expert pathologists here are also able to perform most of that testing for us, which is wonderful because it means we can quickly and readily tell a patient whether they would be eligible for immunotherapy. It wouldn't be something I would consider in the front line, but in a patient who's had a cancer that comes back and we don't have a clear next recommendation, then it can be a test we can perform on the tumor to consider giving immunotherapy. And at Johns Hopkins, we also have several clinical trials looking into immunotherapy in recurrent ovary cancer.
Excellent.
That are going to tell us more in the next few years.
When would radiation therapy be considered for someone with ovarian cancer?
Radiation therapy is really reserved for what we call palliation, which essentially means helping with symptoms. So this
Symptom
is
management.
Yeah.
Yes.
So it typically isn't, certainly not something that we would expect to cure any cancer, but in a patient who has had a recurrence, if that's in a location either causing pain or other symptoms, we can sometimes try radiation to see if that will help if it's not responding to chemotherapy and if surgery isn't an option.
Okay. You mentioned the word palliative. I struggle with the term. Palliative care drums up the word fear when people hear it, unfortunately. And I'm probably the biggest fan in the world for palliative care. For our listeners, I just want to mention a little bit more about palliative care. Palliative care is not solely tied to hospice. Unfortunately, it oftentimes may not be brought up to a patient until a doctor is ready to discuss hospice and then says, it's time for hospice and palliative care. Unhitch in your mind palliative care. And I'll tell you what I see palliative care as being, and when I recommend palliative care, this is my purpose. It is for quality of life preservation or quality of life restoration. We want patients to maintain their quality of life. Treatment for treatment's sake is bad care. We want you to still be living and thriving and enjoying your life that remains and not just being sick all the time. If you have ovarian cancer, cervical cancer, any kind of cancer, and a physician has said, would you like to see a palliative care physician, and you've said no, go back and say yes.
I think that's a great point. I think the term palliative care, it means many different things to many people. What I explain it to mean is essentially they are the experts in symptom control. They will help your symptoms get under control so you can live your life, so you can have that quality of life back. We talked about cervical and ovary cancer today, and those are two of the cancers where in the advanced stages, really palliative care can be incredibly helpful with pain, with nausea, with fatigue.
Yes.
I mean, often people don't realize we have treatments for fatigue. It's really important. And I think patients should know about palliative care. And we have a wonderful palliative care team. And if you're struggling with symptoms from cancer, the palliative care team can partner with your physician to make you feel better.
Yes, absolutely. Absolutely. What advice do you have for women listening today regarding some of the services and programs that are available here? For example, at our Kelly Gynecologic Oncology Services, we have a world-renowned team for which you are part of that team, Dr. Beavis. Mm-hmm. Can you share with us some of the services that are available through that program?
When I think about services available for patients, you have to think about from the beginning to the end. And I think that there's a lot of wonderful things that we offer here that are unique because of who we are as an institution and where we've dedicated our care. When a woman is first diagnosed with a cancer, that can be a very overwhelming experience. And we have a program here, the Susan Burgert Gynecologic Oncology Survivorship Program. This survivorship program, it doesn't necessarily mean someone who's finished their treatment for cancer and now has no evidence of cancer. It's important to realize survivorship refers to surviving cancer, whether it be active or in remission. The lead of our program, Paula Silverman, and her team puts together these wonderful bags with all different supplies that a woman might need during chemotherapy, often with notes from prior women who have gone into remission and are now volunteering as part of this program. Within the program, we have the woman-to-woman program. So we partner women with a mentor of a woman who's had that cancer and has been treated, and we try and pair them based on the same type of cancer, similar treatments, so that they can see women a couple of years out how they're doing. And this has been so incredibly helpful to so many of my patients because a lot of times they're the only person they know who's going through this.
Right, they're not alone.
Yeah.
And they can hopefully see themselves in the future.
Yes.
Which is also really helpful.
It provides a lot of hope, and I think it also provides, especially when you're thinking about undergoing a huge debulking surgery, to see someone on the other end of it who's living their life and doing wonderfully, it can take away a little bit of the mystery of the surgery and also the fear. I have never had to have one of these surgeries, and I do them every week. And so it's very helpful to have someone who has had it to help our patients really understand what it's going to feel like, what they're going to go through, and know that they will get through it. And that survivorship program is there the whole way. It's there when the cancer comes back, which unfortunately most of the time with ovary cancer it will. Through all of those treatments, we can help women. We have to treat the whole patient. Like you said, don't treat for just treatment's sake. We're not just going to throw chemotherapy at people. We have to think about their life goals, their quality of life, their quantity of life. And then I think the survivorship program here has been this just huge complementary addition to our care.
Excellent. Thank you so much for joining me today.
Thank you so much.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gynecologic, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from Biosense Webster, Boston Scientific, and Keswick Wise and Wellness Center that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey, and like us on Facebook and Twitter. Until next time, stay well.